Here's our clinical roadmap for today. We'll start with taking the patient history, move on to the clinical examination, tackle diagnosis and staging, lay out the workup and management plan, and finally, dive into the surgical procedures.
So, step 1, taking the patient history. Let's look at our 45-year-old patient's presentation.
We begin with a 45-year-old postmenopausal lady presenting with a breast lump that honestly sets off immediate clinical alarm bells. Just look at how this timeline maps the sheer velocity of the disease. Over 6 months, she had an insidious onset of a painless lump that rapidly ballooned from a 2 by 2 centimeter mass to a massive 10 by 10. Then about 2 months ago, she developed this dull, aching, continuous pain along with a huge 7 by 7 centimeter ulcer with foul-smelling discharge. It brilliantly illustrates a rapidly progressing malignancy. And hey, quick pro tip for when you're presenting this kind of data: stick to approximate centimeters. Seriously, examiners really don't like it when you compare tumors to fruits or sports equipment. You start talking about lumps the size of a lemon or a baseball, and you'll literally see them wince. Just stick to the metrics.
Now you want to completely take control of your clinical viva? Just state this exact phrase: no history suggestive of metastatic disease. When you say this, you're effectively laying a trap for the examiner. You're forcing them to ask, well, what exactly are the negative symptoms you checked for? And boom, you just rattle off the list you've already memorized. No hemoptysis, no breathlessness, no jaundice, no bone pain. You completely guide the conversation back to your strong points.
Looking at her broader background, the history is otherwise clear. She attained menopause 5 years ago, had 3 kids, all breastfed, and has absolutely no history of oral contraceptive pills. Crucially, though, she has no high-risk family history of breast, ovarian, or colorectal cancers in any first-degree relatives. This negative family history is a vital piece of the puzzle, and it leads us directly into our physical exam to see what the body is actually telling us.
Moving right along to step 2, the clinical examination. Let's talk about listing the vital signs and local symptoms.
Before we even evaluate the lump itself, here's a golden rule. Always measure the vitals yourself rather than just casually declaring them stable. And always examine the patients both sitting up and lying down. Okay, to check if that massive 10 by 10 centimeter growth is fixed to the chest wall, we execute this strict 3-step pectoralis major fixity test. First, you ask the patient to bend forward. If the lump falls away, it's not fixed. But to be super thorough, check its mobility in 2 axes while the muscle is completely relaxed. Then, have the patient press their hands tightly onto their waist to make that muscle taut, and recheck the mobility. If it's restricted when taut, the tumor is fixed. In our patient's case, thankfully, it wasn't.
Now, our patient had 3 enlarged mobile axillary lymph nodes, but finding them requires perfect technique. You have to physically support the patient's arm against your own elbow so their muscles completely relax. And here is the absolute secret. Use the pulp of your fingers, never the tips. If you poke with your fingertips, you are going to miss the nodes. So, you feel for the anterior, central, and apical groups, and then have the patient put their hand on their opposite shoulder to access that posterior group.
This table summarizes the really severe local findings on the right breast, which directly inform how we're going to stage this aggressive disease. The mass is in the upper outer quadrant, and it features a massive ulcer with everted edges and a sloughy floor that bleeds just on touch. Also, notice the nipple is riding slightly higher on the right, which becomes super obvious when the patient lifts her arms, though there isn't any actual retraction. These findings aren't just descriptive, they are the exact parameters we use to calculate the clinical stage.
That brings us to step 3, diagnosis and staging. Time to define the clinical picture. So, our definitive diagnosis here is locally advanced breast carcinoma, clinically staged as CT4B-N1-MX. Let's break that down for a second. It's T4B specifically because the skin is involved, obviously indicated by that huge ulceration. It's N1 because we palpated mobile ipsilateral axillary lymph nodes. And pay attention to this. We use MX because we clinically cannot assess internal systemic metastases just by looking at the patient. Let me tell you, MX is a far safer, much more accurate exam answer than confidently claiming M0 before you've even done a single scan.
And, if anyone asks you why this isn't a rapidly growing phallodous tumor, since those can also present as a massive fast-growing lump, you can confidently point out that phallodous tumors rarely fungate or ulcerate the way this one has. More importantly, they typically do not spread to the axillary lymph nodes. So having both severe fungation and palpable axillary nodes puts us squarely in the realm of advanced carcinoma.
Moving to step 4, workup and management plan. Confirm, stage, and treat.
Our three-pronged workup strategy is actually pretty straightforward. First, confirm the diagnosis with an incisional biopsy. But, and this is critical, you must take it from the viable edge of the ulcer. Avoid the necrotic center, because that's just going to give you dead tissue and an inconclusive result. Second, stage the disease using a PET CT scan to check for any systemic metastasis. And finally, prep to treat the patient by ordering a routine pre-anesthetic checkup, ECG, X-ray, and blood work to make sure she's fit for surgery and therapy.
Because this is locally advanced breast cancer, we cascade the management. We definitely do not jump straight into surgery. Instead, we start with neoadjuvant chemotherapy to really try and shrink this massive tumor down. Only after that do we proceed to step 2, which is the modified radical mastectomy. Step 3 is post-operative radiotherapy to essentially clean up any microscopic local disease. And finally, step 4 is hormonal therapy, assuming, of course, the tumor pathology comes back as ER or PR positive. It's a very comprehensive, sequential battle plan.
Finally, step 5, surgical procedures. Let's navigate the differences between MRM and BCS.
All right, let's step into the OR. The surgical technique here is meticulous. The patient is positioned supine with the arm outstretched but strictly below 90 degrees to prevent any nerve injury. Before making a cut, methylene blue dye is injected for a sentinel lymph node biopsy. This tracks exactly where the cancer drains first. We use an elliptical Stewart's incision and raise the skin flaps with monopolar electropottery. Now, the lower flap is notoriously more adherent and kind of tricky to raise. Once the breast is dissected right down to the shiny pectoral fascia, we enter the axilla and perform a level 3 axillary lymph node clearance, working medial to the pectoralis minor muscle to get all the disease out.
But look, surgery isn't a one-size-fits-all deal. An MRM is a complete removal, absolutely required for advanced fungating tumors like the one in our primary case. However, breast conservation surgery, or BCS, is a targeted lumpectomy. It removes only the tumor with clear margins, preserving the rest of the organ. This has massive psychological and cosmetic benefits. Actually, one surgeon shared this incredible story of doing a BCS on a medical student's mother who had early-stage cancer. Her biggest concern? She had a flight booked to Singapore in 15 days. Thanks to BCS, her breast was saved, the cosmetic result was fantastic, and she literally boarded that flight 2 weeks later. It's a real game changer. During breast conservation surgery, there's this hidden communication happening between the surgeon and the pathologist. You can't just hand them a round, uniform lump of tissue. You absolutely must mark the extracted specimen with a short superior suture and a long lateral suture. This gives the pathologist a strict 3D orientation so they know exactly which margins are clear of cancer cells and which, if any, are positive. To complete this safety net for the patient, the specimen goes for mammography and a frozen section to confirm clear margins, while the axillary dissection is done through a totally separate incision. But before closing everything up with cosmetically pleasing subcuticular sutures, the surgeon actually places titanium clips inside the surgical cavity. Why? Well, these clips act as a permanent target map for the mandatory post-operative radiotherapy. It ensures the radiation oncologist knows exactly where to direct that radiation boost to eradicate any lingering microscopic